Hello. So yeah, we have Dr. Harry Wu, who will be presenting next. He's a historian of medicine, as you mentioned earlier, and an assistant professor in medical humanities in the University of Hong Kong's Li Ka-shing Faculty of Medicine. So just prior to this, he was actually teaching in Singapore, as you mentioned as well, at the LKC School of Medicine and the history program at NTU. He's especially interested in mental health, hazard exposure, and end-of-life care. So today, Prof. Wu will be sharing on his implementation of various medical humanities workshops that he has conducted in the past, along with shifting identities of physicians. Prof. Harry. Thank you.
Oh, thank you, Min, for the kind introduction. And also Graham for initially introducing me to this program. And then it's really exciting to be back to Singapore, although virtually, right? And I will share with you my PowerPoint first. Okay. Right, so this is my topic, implementing medical humanities workshops along shifting identities of physicians. I'm going to briefly introduce my background first. I am a medical historian. By saying a medical historian, that means my PhD is modern history that I earned in the UK. But previously, I was working as a doctor, but also very briefly. Before that, I was clinically trained in Taiwan, and then I moved to Hong Kong, and then did my postdoc in the School of Humanities. And then while I was at NTU, I was jointly appointed between Humanities and Li Kongtian School of Medicine. And then I moved to Hong Kong again. And then at that time, I worked in the medical faculty for 6 years. And then now I just want to update to you my current position. I relocated to Taiwan last year. And then I am working for a cross-college program and also a new department of medical humanities and social sciences in my current institution, which is National Cheng Kung University in Tainan, an ancient town in Taiwan, in the southern part of Taiwan. So you are the most welcome to visit us, and we are developing hopefully the same exciting program as yours. Right? And this is my research. I am a historian that I predominantly look at the development of modern psychiatry. And this is the book I published very recently, last year, about the making of ICD. And actually, I look at how classifications of mental disorders and the standardizations of diagnostic criteria were created, and what politics and cultures are there in a massive organization as WHO, right? Okay, right. So this is the outline of my talk. I'm going to first introduce the development of medical humanities in Chinese-speaking contexts. And then I am going to talk about the rationales behind why I'm talking about the shift identity of physicians. And then I'm going to reflect on the two workshops I designed for different medical schools. Right. First of all, the development of medical humanities. Now, actually, if I ask you what medical humanities is, among ourselves, we perhaps will come across very diverse answers because all of us are experts, but actually none of us are experts as well, right? And to historicize medical humanities a bit, it was something that came about in 1960s. So it already has a history of more than half a century long, right? And so far, there is no clear definition of what medical humanities really is. And but if we put medical humanities in the East Asian context, we mostly refer to that in Anglo-American context, right? So this is in 1960s, people began to talk about medical humanities. And for me, I guess this is, we need to look at a little bit the background, the cultural, historical background of what people are talking about in 1960s. Actually, this is C.P. Snow's two cultures, right? And he was a chemist and also a novelist. And at the time that he wrote a very, very impactful book that criticizes that there are actually two cultures in the academia. In science, he observed a community of scientists and engineers. And then he said that, okay, well, we need to look back at the time of post-war rehabilitation period where people really look ahead. And they were really optimistic about the development of modern science and technology, and that can really drive people to survive from the devastation of Second World War. So there was this huge optimism there. But then if you look at the community of comparative literature, that this is another observation he made. He observed that people were very optimistic and very critical of what scientists are doing, right? And so this is a two cultures divide that mentioned by C.P. Snow back then. And so this is a background where people are talking about whether or not there should be some kind of interdisciplinary work. And then if we look at 1977, that this is also a famous quote by Ivan Illich. He is a philosopher, and when he was making observation among doctors doing diagnosis, he said that, okay, we doctors just now we diagnose patients and then we don't need to see them in person. We just diagnose them, treat them according to the chart. We don't need to even see their faces. We don't need to directly engage with them, right? So this is Ivan Illich. But if we look further back to 1930s, perhaps we can find another doctor who made very similar comments, who was Herbert Cushing. He was a neurosurgeon at Johns Hopkins Hospital, right? And he was already aware that the specialty division had made doctors not able to understand what other specialty people are thinking or talking about, right? So you can see that over the past century, that there were a lot of people reflecting on whether or not it's a specialty or the disciplinary division, right? And the need to really develop something that is more integrative or more cross-disciplinary. And now this is medical humanities developed in Taiwan, Hong Kong, and China. And actually, if you are interested, then I've already written this up with my colleague in Hong Kong. And we reviewed the program development of medical humanities in these three different regions. And they were all implemented along the opportunity of pedagogical reform in higher education, right? And so I don't want to go into details. So I just flash the slide. And if you are interested, just read this article. I can give you the full context, full article as well, right? To put it simple, I mean, medical humanities developed in these three regions, they share similarities. One of them is this: it's Me Too. We know what Me Too drug is, right? But this is a Me Too program. That means in these three regions, people don't grow their own medical humanities programs. They learn a bit of bests from elsewhere, right? And why is that then? Just simply look at Taiwan, where I'm currently working. In the 1950s and 60s, people share a kind of sentiment that science is the thing that leads state development. So the government poured a lot of money into the development of scientific education and also scientific research, science and technology research and education. And then people don't ask about the value of science, like what in Britain, for example, there was a huge debate and also a growth of so-called history of science, history of medicine, looking at regarding the activities of medical practice and medical research as a kind of a cultural process. We don't have this kind of reflection or debate. Therefore, we don't question the value of science, taking it, just regard it as something that we have to worship, right? So that means we don't have a soil to nurture the growth of this kind of debate, discussion of debate in East Asian culture, right? So now there are more and more humanities or social sciences scholars ionized from medical field, clinical medicine, to study something else, like myself. And actually, in my own department, now current department, we have 8 faculty members. Half of them were medically trained before, right? And then, so for us, we became sociologists, we became anthropologists, and we became, like myself, I become a serious historian. And for us, humanities is something just about feeling good. It has to stimulate deeper thinking across humanities and social sciences. And we have to critique conventional approach to medical humanities beyond just pure enthusiasm or passion, right? So for us, while we know that in a lot of programs, medical humanities focus on the soft skills like communication, it wants to really stimulate or encourage or nurture students' capacity of empathy or compassion. But for us, it's not only that, we need critical thinking, right? And so this can be best exemplified by an editorial recently published in Lancet. Look, COVID-19 is a perfect opportunity for us to really understand that medical practice is not only medical science, right? So we need to understand that, for example, the slow rolling out of vaccines, it has something to do with inequality of, for example, like different career, gender, race, wealth, and geography, right? And in order to understand this kind of thing, we need to have a more integrative system comprising of history, politics, economics, etc., etc. Okay, right. So this was already published already 5 years ago. I proposed that there are 6 keywords, 6 domains that we can kind of think of in developing critical medical humanities programs. And I don't want to go into details, but I lay out 6 domains: identity, gaze, stories, content, citizenship, and uncertainty. And today I'm only focusing on identity, right? Okay, right. So second part of this presentation, shifting identities of physicians. If we look at this picture on the left and on the right, this painting, painted by Picasso, right? Pablo Picasso, that is about this, the name of this painting is Science and Charity, okay, and it was completed in 1894, okay, 1894. And if you look at the picture, this woman who apparently is the sick person, she's in the bed, and then the gentleman on the left is obviously the doctor, right, trying to take her pulse, and then he was pondering what's going on to this woman. And then there is a nurse, as well as also a nurse and also a nun, right, holding her child, looking after her. And then on the right, this is well, actually for Picasso, it took 5 years for him to complete this painting, right? He had to make a lot of sketches first and a lot of drafts until in the end that this painting was completed, and now it's in the Picasso Museum in Barcelona. Okay, on the right, this image was taken from the history introduction of Johns Hopkins University. At the end, in the last decade of the 19th century, this was also the revolution of medical education occurred from Johns Hopkins University when William Osler proposed that we need to really professionalize medical doctors. Now, medical students began to wear white coats, and then we emphasize on cleanliness, right, etc., these kind of ideas. And then if we compare these two pictures, we can see that on the right, the patient is gone. We don't see the patient's face at all, right? And then these doctors, they are facing the camera with a kind of a very confident look, right? I represent science. I represent the most advanced kind of profession, right? And then, so this clearly corresponds an article that was written by medical sociologist Nicholas Jewson, who wrote this article in 1970s called "This Disappearance of Sick Man." He talked about the development of modern medicine. In the past, we diagnose a person at bedside as a person, and now we treat patients we don't really need to see the patients themselves in person. We can diagnose them, treat the cell complex. We can draw blood from a patient and then look at for example, your neurotransmitter level. We can measure your enzymes. We can analyze your tumor markers, and then we treat cell complex. We don't treat a person. And then this article was so powerful and influential that the International Journal of Epidemiology reprinted it again several years ago, right? And then there are a lot of other people talking about the coming back of sick person again, right? So if you're interested, you can just look at the evolution of this article and then how people looked at it, right? Okay. So the shift of identity, physician identities, it developed along, for example, the change of disease characteristics. Now we are entering the age of chronic diseases. And for chronic diseases, the disease change or develop according to these different factors: lifestyles, uncertainty outcomes. For example, like each episode in one single disease is different, and they change according to stress events, stressful events, etc., etc. To put it simply, there's no longer a quick fix to our modern people's suffering. Okay, so and several years ago, this was already a while ago, anthropologist and physician Arthur Kleinman, he wrote in his book, famously differentiating disease from illness. For example, like illness is a kind of subjective perception, how sick person and the members of the family of wider social network perceive, live with, and respond to symptoms and disabilities. And disease is more objective. It is about what the practitioner creates in a recasting of illness in terms of their theories of disorder. In the end, these two different perspectives develop very different ways of looking at diseases or their concerns. What patients and families are concerned about during for example, like an episode, what caused my current illness? If I am diabetic, what caused my higher level of blood sugar at this particular time, right? Why did I become sick at this particular time, this moment? How does this illness work inside my body, and how does it affect my work, interpersonal relationships, etc.? How would it happen to me at school, work, family? How should I be treated? What are the resources for me to get better? And in clinical world, people are concerned about etiology, about the time and mode of onset, the course of diseases, whether or not this is acute, chronic, or it will eventually cause disability, right? And then so we recommend treatment according to different theories, evidence, and guidelines. We have evidence-based medicine, right? And we also have a lot of guidebooks to follow, right? But actually for chronic diseases, and not only really chronic diseases, people look at things differently. So according to Arthur Kleinman, that physicians have to develop so-called perspectivism of looking at things. That means we have to transform ourselves from a clinician to become an ethnographer, like throwing ourselves as knowing nothing about the event, about the culture, and to absorb everything, learn everything from what has expressed by patients and families. And according to Kleinman, he said that an ethnographer is deeply respectful of alternative interpretations, especially those of his or her informants. And they are interested in cross-cultural differences. And this is more important while we are practicing in East Asia. Or like in Singapore, this is such a multicultural place, right? Okay, so this makes the shift of clinicians. In the past, we were physician-centered. No, I mean, if we look at in earlier history, that we can say that this kind of physician-centeredness began from the end of closing decade of the 19th century. Before that, it was still person-centered, right? But now we had to revamp the whole thing. So since the maturation of modern medicine that we experienced this, we created the so-called the disease model of suffering, physician-centered, biomedical focus, and we focus on intervention, and then we want to see outcomes. We want to see remission of diseases, but not necessarily suffering. Now, we need to focus on, this is a language taken from modern psychiatry, recovery model. It is more patient-centered. It is so psychosocial focused. We look at observation. We provide company with patients and families. And we don't look at, it's not that we don't look at outcomes. So on top of outcomes, we look at how a person functions well in the family, at their workplace, in the society. And then, for example, yesterday, there was a famous science writer, Laura Spinney. She wrote on Nature about the long haul of COVID-19. So from this point, she has made clearly that we need to pay attention to what COVID-19 patients, when they were disabled, I mean, they can be put into the category of a disability, and now we have to, it's no longer for example, like COVID-19 is no longer a one-off event, right? The legacy will stay for a very, very long time, and what we should do about it, right? So, yeah. The problem is now, when we are talking about physicians' identity shift, one of the solutions is to promote interdisciplinary studies, right? But in reality, what happens in a lot of institutions is interdisciplinary studies still in silo. What do I mean by that? Is that in each department, we have our own medical humanities experts. But in each department, these medical humanities experts, they don't reach out to other departments or faculties, medical humanities experts. Why is that? This is in another paper I published in 2018. I talked about that the internationalization and interdisciplinarity, these two ethos that were pursued by top universities in Asia, they don't actually play out together, right? Why is that? And then, in the end, is that medical humanities have failed to challenge accepted and comfortable medical norms and assumptions making little progress beyond tinkering around the edges of medical education. I think this is such a wonderful quote. And so a medical humanities scholar can often become so-called the token of minority for a university to sell to other people, says, look, we have this program, but with this program, we don't really change anything. Why is that then? This is a very interesting study by Matthew Abbott from, I think, Wilson Center at Toronto of Medical Education, that he observed a lot of social scientists working at medical schools. And this, he made a lot of observations, and this is combining my own observation. Look, the working environment for a humanities scholar or social scientist working for a medical school. Now, there's a tension about promotion and tenure, right? So look, to put it simply, we want these social scientists or or humanities scholars to work in a medical school, and we want them to speak clinicians' language, and they find it hard. And then in medical schools, it is we measure or evaluate scholars using metrics. For example, we require a humanities scholars to publish high impact journal papers. This is so ridiculous when I reflect on my own experience. When the faculty was doing this kind of RAE or REF exercise, they want all of the scholars to submit their best articles to be evaluated. And they say, okay, anything below impact factor 9, you cannot submit it. And I'm a historian of science. My best journal is ISIS, published by the University of Chicago Press. It has more than 100 old history, this journal. And the impact factor of that journal is 0.79. Okay. So how do we survive in this kind of a harsh environment then? Yeah. So that means this kind of practice was discourage medical humanities scholars working in the medical school to continue their own research, right? And then in terms of teaching, right, what I can deliver to my students can only be reduced to very, very simple concepts. There's no time and space to really stimulate students to critical thinking. And students, when they come to me, they all ask me about, what's the takeaway of today's lecture, right? I say, I'm not McDonald's. I'm not going to let you take away anything, right? If I'm able to make you confused, I'm successful, right? So this is so far. I mean, unless like NTU, you have a very strong institutional support. If you don't have this, then these scientists, humanities scholars and social sciences, will suffer a lot, right? Now, I reflect myself as a communicator rather than a researcher now in developing medical humanities programs. So it is difficult for one single faculty member, only one in my previous university, right? And we need to cater for a cohort of more than 1,500 students in total, right? How do I do that? I need to rely on the help of clinicians. So I need to become a communicator, right? And so it is very interesting that when we are shaping one medical humanities programs, we need collaborations. And it is often us, humanities scholars, who become a communicator. It's not clinicians. Clinicians are too busy, right? So I will reflect on the 2 workshops I designed in Hong Kong U and in my current university, NCKU. And what I do is to really let all disciplinary experts stay in their own comfort zone. Right? That means we appreciate each other's disciplinary's value. But still, through these programs, through the design of these workshops, we don't require you to learn new things, but we can work together. Right? And first of all, this is Building Self-Compassion workshop that I did in Hong Kong U. Right? These are learning outcomes. The workshops is only 3 hours for year 4 preclinical students. They need to describe the relevance of compassion and self-care in medical education and clinical practice. They need to reflect on possible emotions with doctors in response to different illnesses and conditions that will affect the quality of treatment and care. They need to explore possible ways to deal with negative emotions and equip themselves with knowledge and techniques of compassion before clinical exposure. They sound a little bit grandiose, right? But this is the aim, right? So this is what we do. Where's the role of physician then? There, in the middle, physician experience sharing. So it takes a humanities and social sciences scholar to introduce the first part. Why is there, and why do we need self-compassion? Why is that so critical? And then we invite a physician to share his or her experiences in taking care of patients. And then we read a creative writing piece, and then we do reflections. So these are the 4 procedures. Now, why do students need this self-compassion program then? This is people are talking about fatigue, compassion fatigue, talking about physician burnout, and we want to prevent that. So we first collect students' feedback on their own curriculum, and we find that there's this kind of messy stuff going on in their mind. And then I don't go into the details. And we find that it's not only for example, in clinical rotations, they suffer from this kind of panic when they need to sit from one program to another program. In preclinical years, it's the same, right? So, okay, all right, yeah. So after we introduce the basic concept of physician burnout, compassion fatigue, and also all the theoretical backgrounds behind that, we invite in each workshop, we invite one clinician to reflect on their practice and select, for example, the best scenario that can encapsulate all the backgrounds of why we need self-compassion. And then together, ourselves, clinicians and students, we read a very short piece of writing. And for example, in this workshop, we selected Daniela Ofri's A Daily Dose of Death, right? And then, of course, she's such a proliferated writer. And then recently she published another book I highly recommend it. It's called What Patients Say, What Doctors Feel, right? What doctors hear, right? And then students will do reflections. Through this kind of activity, I use body mapping, right? And because students, in East Asia, they tend to be quite reserved. They don't speak up, right? So I let them do activities. So this is body mapping. So I would just use, for example, like a group of 5 forming a small group, identify in the writing any story you hear, any little scenario that they come across at this day, and then choose 2 members. Each will lie down on the 2-meter papers to stimulate postures best resembling the patient and the doctor, and then sketch out the patient and the doctor, use any symbol and color to refer to possible emotions this doctor is experiencing. Now, this is the most important part. like just now, Michelle was talking about making sense of these emotions, right? This is what we do to let students to make sense of possible emotions this doctor in the story is experiencing, and then we come back to let the doctor invited to share his or her practice again, right? So this is something we are experiencing. We have been practicing. I need to screen this short video and I share some. Okay, yeah. So this is another creative practice, right? But this is a professional theater. Right? The second workshop I'm reflecting would be something that I am experimenting right now. So it's also about self-care, right? Now this is Grace Under Pressure, produced by an Australian documentary theater.
My dad is actually a fireman. And my mum's a registered nurse, so I was around that environment of shift work and action and stories. I just loved listening about them. So I joined the ambulance service, and I worked with them for about 6 years full-time. Then I went part-time and I did my nursing. I didn't want to do ambulance forever because I was seeing what was happening to my colleagues. I was seeing what was happening to me. So then I decided to study nursing.
So you're still doing some ambulance work?
Yeah, I am, just on a casual basis now. So just work on my days off.
You work on your days off?
Yeah, but I love it.
I loved it.
I love nursing.
I loved being able to go and talk to patients.
And so much. It's not just the physical hands-on.
And it felt like a huge privilege that someone you had just met was prepared to tell you their most intimate details.
And he goes, start CPR. And I was like, oh, okay. So I jumped on it. And I'd never done CPR before in my life. And he's like, okay, just slow down, right? Because I was like going like a jackhammer, you know what I mean?
We were walking down the corridor together, literally chatting and having a cup of tea because there'd been one of those quiet moments when we walked past a patient who was, looked pretty dead to me. I was like, shit. And so we hit the red button. And then we realised we were it.
First baby I ever delivered just shot out, had to catch it in slips. I mean, it wasn't just easing out, it went whoosh. I mean, I got it before it hit the ground.
I think people are very confused about what a nurse's role is. Medical staff are very confused about what a nurse's role is. I think many of them don't appreciate that we have a different role to them.
I'm in my intern year now, and I have been saved so many times by the nurses. Like, there was this one time I was in the cafe, and I get this call, and it's one of the nurses, and she says, did you mean to write 1.5 milligrams? And I was like, no.
I see my job as helping patients, not helping doctors.
So
the respiratory...
All right. So this is documentary theater, or in a more professional term, it's called verbatim theater. And the production of this kind of theater is really to capture the interviewees' words, their narratives, word by word, like a documentary. So like a documentary, that means we use the actors' bodies and their voices as lens of cameras to produce a documentary, right? And then I learned documentary theater in the year 2019 in Australia. And then I wanted to transform this kind of theatrical experience into a pedagogical program, right? So I designed this workshop like using verbatim theater, verbatim care. So this project aims to explore the burden of care and coping strategies among multiple caregivers of XYZ patients through the production of verbatim theater as a knowledge co-production medium through illness narrative interviews, playwriting, acting, and community-based performances. The project will create a sharing platform for knowledge and emotions among participants leading into an example of compassionate community. This is also quite grandiose, but I'm just now experimenting it. This is what we do. We recruit a group of students, not more than 20. But then after doing that, if this is successful, then I'm going to expand the program to the entire medical school, right? And also paramedics, right? And ideally, the student compositions should be cross-disciplinary because they can learn from each other. So this is what we do. We first introduce what medical narrative, a illness narrative is. And then we train students with a particular tool of illness narrative. And then, so they will go out and select a kind of caregivers. So some students, they choose different caregivers of mental illnesses. And then some students, they choose family caregivers. Some students, they choose for example, like clown doctors. I don't know if you have ever heard of this clown doctors. This is a kind of kind of performance group originated from France, right? And then if you are interested in clown doctors, you can look at I think 2020's BMJ Christmas issue, right? They've got a very interesting article introducing this group of clowns who became caregivers in a children's ward, right? And then they will interview them. They do in-depth interview. We also train them to conduct in-depth interviews. And then you need to transcribe these interviews onto the computers or a piece of paper, and then including all the emotions, all the gestures, all the facial expressions, right? And then they need to transform all these transcriptions into a play. So there was a bit of another training of what screenwriting writing is like. So we watched a movie together, and we analyzed the scenarios of the movie, and then to analyze how these characters in the movie are shaped, are built, and then what the storylines, in what way these storylines evolve, and then how did the director or the screenwriter try to make conclusion, right? So on the left, this was like an acting training, right? And we invite actors to train students as well. And on the right, this is like the editorial training, the drama editorial training, right? So this is a kind of 6 weeks short course, right? Although I think it can be expanded to maybe 2 or 3 months, right? But actually, because of the COVID situation, we choose to really implement that. Well, after in Taiwan, the COVID restrictions were lifted, right? So you can see that we choose to do the training in a outdoor space where we have more ample air ventilation, right? And then so students, through this kind of activities, students can learn from each other, learn from from caregivers' narratives, right? And they, through the drama script editing, they identify what's important, what's anything that they are not aware in the past in terms of providing care, right? And then, so I also invited a professional theatrical group to do exactly the same thing, and then to produce a demonstration. A demo model version of verbatim theater, right? And so we put that production onto the National Theater, right? So this is the trailer.
我觉得啦，可能就是影响很 很多的手脚的动作啊，然后他眼睛也不太能睁开啊。
It's in Mandarin, so bear with me for 1 minute.
就是说，他整个人的世界是变得很黑暗的，所以他很害怕睁开眼睛。
All right. So, students' feedback. I became more aware of that caregivers also need to care themselves. I used to think that care is given without complaints, regrets. But I learned that there are actually different voices. I realized that care should be the starting point of treatment. Many critical moments emerge during the process of care. I learned to excavate myself and to find a position the most suitable for providing care. Right? There are many of them. I just take maybe 4 or 5 of them to share with you. Right? So, and then students also share professional healthcare workers. Right? And then I don't really define who care workers are. Students can define among themselves, right? So I want to shake up the disciplinary boundary, right? And then these people, these professionals, they just stay in their own position, right? So this is a kind of a workshop design philosophy. And then I am still experimenting it. And then this year, I am collaborating with the palliative ward in Taiwan. And then so they are going to provide me the palliative care doctors, nurses. And then when we are producing another documentary care theater, we will also include actually anyone in the ward. For example, like a cleaning ladies, who provide also direct contact with patients. They are also important carers. And we believe that some very critical moments can come from their words, right? So this is what we're experimenting. And I hope that I can expand this practice to other hospitals, schools, and perhaps in communities in other countries, right? So if you are interested, I invite you to get in touch with me, and perhaps we can do some research together, and we can also create some programs together, right? So I will leave more time for discussion. We have half an hour, right, before our lunch break. So I'll stop here, and thank you very much.
These are the fantastic workshops that you have planned and have conducted in the past. Very creative. And it really sort of showcases your just investment and interest in the medical humanities as a field and bringing it forward as well. Does anybody have any questions at this point to ask Harry? I think perhaps I'll start. I think we just to clarify a little bit. So you mentioned that the second workshop was a 6-week short course, and the first one was a workshop on its own. Was this incorporated into the formal medical education curricula, or was it a standalone sort of course?
Okay, the first workshop about self-compassion, that was in a form. It's a mandatory workshop, right? But it's only very short. It's 3 hours for preclinical students in Hong Kong. And then the second workshop, I'm still assessing how we can best implement it in a formal medical curriculum. And I hope that it will become mandatory as well. Right.
And I think one of the things that came up, I think, when I was sort of listening to presentation, when it comes to evaluation tools or assessments. So, for example, with the first workshop, as in, again, since it's incorporated into formal education, were there expectations for students to be formally assessed a certain way, or was it based on reflections, reflective writing?
I think, it is really difficult to assess students' performance in humanities. And some, I guess among maybe 250 students, there are some students who perform naturally better in terms of creative writing or something. So for medical humanities, my idea is just pass and fail, right? Beyond expectation, merit the expectation and below expectation, that's far than enough, right? So, so this is very difficult to fail. If you fail because of absence, I call you back to do another workshop, right? And students will feel very embarrassed when they are called back to do another workshop with me, right?
Okay, thank you. And I think on another note, you mentioned sort of shifting identities of physicians.
Yeah.
And this new identity as a communicator. Can I just maybe ask, what does that look like? And when it comes to sort of experts staying in their own lane, right, staying in their own line of work, how do you then start these conversations as a communicator?
I think we need to find common grounds, right? And you really need to find opportunities to open up the communication. For example, in my current university, we're building a hospital for the old aged individuals, and then so that means when everything is still loose, everything is still not in good shape, that's the best opportunity for us to step in. And then you just really befriend with these people who are involved in building the hospital. And then, for example, I'm trying to sell this program to some of this documentary theater program to some people involved in the hospital building, right? So find opportunities, right? And then what else? I guess also I guess I'm lucky enough that in Taiwan, there are more and more physicians becoming anthropologists and social scientists and historians, right? So I enjoy this kind of environment. And then for example, medical students gradually see that this is also some career pathway that they can follow, right? And so we perhaps it takes time for us to produce more like-minded people. Okay.
Were there maybe misconceptions that the other experts had as to what medical humanities was or what their role was in this sort of, co-collaboration?
Again, if we find common grounds, I don't think people would really criticize us. Right? If we are providing something that happens to what they need, right? That's the best moment.
Okay. Inkun, any thoughts?
Yes, thanks, Harry. I think it was a very inspiring presentation, actually. And I think if you're looking for collaborators, you're really in the right place because we have educators from all levels and some in management, senior management as well. So maybe I'll just start with one question. What brings to mind when I saw your presentation was that the programs actually gave the participants a chance to experience encounters, some clinical, some non-clinical encounters that they may not have had the chance to do so if they were to just go for a physical attachment, for example. And I think that's important because experiences are actually what we gain as clinicians along the way. And traditionally, we used to say that, the senior consultant, for example, has this sixth sense because of experience. They know how to anticipate problems and thus put in interventions early. So do you see your workshops as providing that kind of alternative when students are still very new and don't have the experience to actually gain that kind of expertise?
Yeah, thank you very much, Inkun. This is such an important question. And I would say one thing. While I was in Hong Kong, there were also 2 workshops that received the best feedback from students, is that we invited, for example, patients recovering from stroke in terms of how they suffer, outside hospitals, right? And also we invite caregivers of mental patients in terms of they share with students how they suffer, how they manage to strive to survive in such a hostile society. The thing that I want to say is we don't need to design the structure of the workshop at all. We just let them speak. And then students are so reflective after listening to their sharing, right? So early engagement, experiences sharing. I guess this is the most powerful tool that we can make best use of, right? I totally agree with you, Minko.
Hey, Dr. Harry.
Hi.
I wanted to share some thoughts. A couple of things I was reflecting on as I was listening to your session. You were saying that medical humanities has to go beyond just raw enthusiasm and reflection, and it has to be more than that. And for me, I'm an advanced practice nurse, so I mean, as I listen to all the sharing, I myself I'm thinking of how to engage my own nursing community. And my setting is the ICU, where nurses really don't have protected pockets of time to maybe go for webinars or seminars. But I've actually been planning for a while. Actually, since the medical humanities course a while ago, I've actually been planning for a while how to engage the nurses in the ICU, because I really, really think that medical humanities is so relevant in an ICU setting, dealing with, dying patients and emotional family members. And, I was just wondering whether you had any advice on how possibly the content of a webinar or a seminar could maybe be broken down into maybe bite-sized pockets of content that can be delivered to maybe the ICU nurses or maybe even my junior residents, the junior doctors in the ICU, because I work closely with them too. Maybe like how it could be delivered in like bite-sized sessions, and when I say bite-sized sessions, maybe even like half an hour, would that be too short, or even like 25 minutes, and delivered on a regular basis. So I think earlier on we had a lot of discussions about engagement and maybe along the lines of sustainability as well. And so I've always wondered whether I could do something that is that goes on, like maybe once a month or once in 2 months, but it has to be really short. And you also mentioned that people always ask you like, what am I going to gain out of this, right? And sometimes you don't really gain something concrete or something very very obvious. But in this setting, I kind of feel like I have to deliver some takeaway, because if I pitch this program to, let's say, the nurse manager, she's going to ask me, what are the nurses going to gain from this? So I want to also some kind of outcome measurement, which is sometimes so difficult to talk about in terms of medical humanities, because there may not always be an measurable result or an outcome. So just wondering what thoughts you had on that.
Thank you, Joanna. This is such a difficult question. I mean, if we really want to to deliver medical humanities within a very limited period of time, the best moment is to find, in my own experience, to find examples of the limitation of science and limitation of our clinical capacity. Examples. For example, I talk about why do we have medical reversals? Why do our guidelines have to change? And why have we, for example, spent so much money in synthesizing a drug that can delay our memory deterioration, but we still cannot find anyone, and then these people suffering from dementia are still dying? Why is that then? Like, we find this kind of examples of our own limitation as starting point for a meaningful discussion, right? I guess this is my solution, right? And then, for example, that perhaps we don't need to use designated time to do it. We can initiate among ourselves, among professionals. Like, I don't know if this is happening in Singapore, but in Hong Kong, there's no such a thing called Balin group among doctors, among family physicians, right? For them to really to be able to share with each other in a confidential and non-judgmental environment in terms of how difficult practicing is, right? And in Hong Kong, because we are in a culture where people tend not to share with other people their own mistakes or their own failure. They're so competitive. In Singapore, people are even more so because of the cancel culture, right? But I think this is so needed. So, some reflection. I don't have a practical solution right now.
Thank you for the suggestion. I'll definitely try that. Yeah, I think it's quite interesting because there's definitely a lot of limitations that the nurses can see for themselves, in the ICU, that, science is not always the answer. And yeah, I agree that could be a great conversation starter. I'll think about that.
Thank you.
Anyone have any questions to include?
Maybe I'll ask one more question. Thanks. So my question is, I think there's a perception that the humanities are actually more developed in the Western countries. And in fact, when I first started kind of trying out programs, the materials that I use are actually Western films, right? And movies that may be popular. So in your experience, Harry, when you implement programs in the Asian kind of context, do you really have to source out your own material? Do you create new material in the first place, or how do you reconcile that?
Yeah, thank you, Ying-Kun. We do build our own bank of resources, right, that are relevant to our own cultural context. I think this is important because students really, they want, what they want to find in the program is relevance, right? And so, but actually having to balance between the local context and the quality of that resources, that's difficult. I know. Yeah. So still, we are still trying hard. And I just want to briefly respond to Joanna again, right? In terms of, there is something that we are trying in Hong Kong, is that entering clinical years, students were scattered around in different rotations, right? And then it is difficult to summon them, and then for us to give them another lecture or another seminar. So we heavily recruit clinical tutors and to sell them our programs, and then to call back students from different rotations only for 9 hours within the 2 years of clerkship. And then, so within these 3 hours, divided into 3 times, and the students reflect on what they see in the hospital, and then to compare what they learn in medical humanities programs, and to see if they can really apply, or it is difficult to apply them onto their clerkship. And then we invite these clinical tutors to discuss with students, why is that so? Why is it so difficult to apply for what you learn from the program, and then to the realistic setting? And then again, we don't need these tutors to learn more new things. And this is a great opportunity for role modeling as well as catharsis, right? And then we ask clinical departments to recognize the teaching hours of these clinical tutors, right? So because they also need, in their own career path, they need PNT, and then they worry that this kind of teaching doesn't really count as clinical teaching, but we ask departmental heads to really recognize their efforts and their assistance, right? So this is what we do.
Hi, this is Yi Pin. I'm a social worker and a psychologist from Cancer Center. And I have interest in what you mentioned about the Berlin group, because that's what we actually tried doing in SingHealth centers. Well, in a very small way, we started with the gynae residents mainly. and also in small efforts here and there. Just wanting to hear your own experience with Darlene's approach with perhaps in the Asian context and also among the doctors and clinicians.
So you mean my experience of what? Sorry.
In the Darlene approach.
Oh, Darlene approach. No, I haven't got involved. I haven't got involved in Darlene.
Okay. Yeah. Because we also noticed, I think, from what In-Kun mentioned and you too, whether that's something that the Asian population, at least the clinician, take too easily. So that's the swatch round and whether it's the Darlene. Somehow we have, running this group, sometimes we have our own doubts and just wondering whether there's an adapted approach that you have tried.
The workshops I just now shared was a remodeling of Darlene group that I created for preclinical students. And then we did, there was some moment, for example, like a student after the workshop, he wanted to stay behind because he said, okay, no one has talked about anything like this in the entire medical education, and now in the next day he's going to sit in psychiatric examination, and because one of his aunts is dying, and then he could not really process his emotions, and he kind of take that as a perfect opportunity to reflect what he is suffering from with me. And so I feel that the value of that workshop suddenly after he spoke to me. And also we managed to find out something. We managed to find out some students were verbally abused by a professor, right, in one rotation, right? And then so using that as an opportunity, we managed to really to report that to the disciplinary committee of the,
Thank you. Yeah, that's really helpful because I think that's similar experience we have that when they have the opportunity to reflect. And I think with In-Kun, we've actually also run some sessions for palliative care doctors in the past, and we find that those who do open up to share, we can see that the processing going on, and I think that's very powerful because we can see that they're obviously revisiting some of these early experiences, which to some extent can be quite traumatic. And so I think that's really great. We'll love to connect with you. I think my colleague Emily is also on the call, and thank you for sharing with us.
You're welcome.
Hi, I'm Natalie. Can I ask Harry
a
question? Hi. So I am a doctor who works in palliative care and internal medicine. We run a medical humanities elective actually for our students, for medical students. It's just started last year. We had our first batch of just a couple of students, and this year we have another 4 to 6. In terms of your sharing just now, you said that you had students who found it very useful when they talked to a stroke survivor or caregivers and heard their stories. And after that, was there any need to put in any sort of structured reflection or debrief or anything like that? For them to kind of crystallize their thoughts and think about the humanistic practice of medicine. How do you do it? Because right now what we do is we just bring them on our rounds. There is a lot of course, there's a lot of rich material dealing with palliative patients. They also have sessions with the art therapists, music therapists, as well as an anthropology tutorial with Janet, who's here. But I don't really know what they get out of all of it. We try and get them to do reflective writing after that. But as of now, we are really new to this, so we don't have a very strong structure.
Yeah, thank you, Natalie. This is a very important question. And according to my experience, after any workshop or after any whole years of different activities, a session of debriefing is important. And then this is something what we are doing, just like this kind of a non-confidential and non-judgmental environment consisting of all people involving in the program to reflect on what has been going on, right? This is important. I mean the space. We definitely need one space. Half an hour will be enough. What we do is 1 hour. Yeah. And then we will produce, for example, like what we do with these clinical tutors is that we produce a guideline for them to follow, a set of questions that they can ask students, right, during that particular hour. And then we, after the discussion, we want tutors as well as students to write down their feedback on the entire thing, and then we try to analyze them in the end, right? So creating the space, that's important, and confidential, non-judgmental, and then we want to treat everyone equally, no matter what position you are. You're a student, a clinician, you're a professor. Everyone should be equal. Right.
Thank you.
Just on that, Harry, how do you select or train your clinical tutors? Because it's not a risk-neutral activity if not done from a position of psychological safety. So it's really, it's like any authentic debrief. If it's done properly, it can be profoundly transformational. It can be cathartic, as you mentioned. It can be it can create wonderful learning and insight. But the corollary is also true. If it's done badly, with malintent, with poor skills or capabilities, it can do more harm and even create harm. So I'd just be interested to hear how you firstly select and then develop and or train or credential, validate your facilitators, because this is quite a high risk activity if done badly.
Yeah, thank you, Professor Koran. This is definitely our challenge too. We will do staff development training like this, right, before we run the whole year-round workshops as such, and then we will really brief to these future tutors what should be done in these workshops. And then, of course, actually we sell our program by connections first, by people we know, right? But then we gradually receive interests from clinicians who want to sell their own religious programs to students. Right. So we will have to stop them from doing that. Right. And then we gradually found it's becoming quite difficult during the COVID-19 years, these 2 years. Right. So still, this is our challenge, and we are still trying to find the best way to restructure the whole thing. But the pity thing is that I left Hong Kong U, and now, at my own new university, I think I need to reinitiate something new. Yeah.
I have similar concerns to what Professor Kieran shared. Like I know that eventually I can't be sustaining a medical humanities program by myself, so I'll need to train other facilitators and other trainers, but how to really choose the right people who really have the right passion and the right enthusiasm, because I completely agree, if it's not done with the right motivations, then the learners will, unfortunately be even turned off or may not see the real point of medical humanities, or may not fully appreciate it. So something that I'll have to think about as well.
Yeah. Yeah, I think this is also a great opportunity for me to reflect on my own workshop design. Yeah, still a lot of challenges.
Have you ever had students who got angry, and how do you deal with it?
So far, luckily, not so much aggression that we found in the workshop, right?
Hi, I know it's 12. Sorry, can I just say a few minutes only, few things. My name is Roshan. I'm a geriatric associate consultant. I'm like the newest member of SingHealth Medical Humanities, so I'm still developing my understanding of medical humanities. But thank you, Prof. Wu, for your presentation. It was really very very good. I learned a lot from that. I wanted to add to Joanna's point about ICU and how to bring on some medical humanities into the ICU setting. I think actually it has a lot of role in ICU because it's a very stressful environment, both for the patients, the families, and even for the staff also. So rather than having a formal program, is it like possible to have something informal, like, I feel that updates to family have become very robotic. People just update them about the condition and then that's it. It's like what Prof. Wu said in the presentation. Now, previously they look at people as people, and now they look at them as cases. So that's what the juniors are doing a lot now. They are just a case, which case, or that case, okay. But they forget that the person is actually a person also. So family have emotions running. The patient himself, even though he's intubated and sedated, might be having his own feelings. So I think having like a debrief, even over a cup of coffee or even lunch, to understand what a patient, what a family might be feeling with the current condition the patient is suffering from. I don't know if that will open the eyes of some juniors, some nurses, so they can deliver care better to the ICU patients. That is one aspect where it might be useful. Second aspect is for the staff who are burnt out, either from an outcome, from adverse outcome from any patient, because ICU, it's 50-50, they can either get better or they can not, so some people have adverse outcomes and it might affect the staff. And also at the same time, family members, patients might also say words to staff which might be hurtful, but again, they should be invited to reflect on what the patient's families might be feeling at that time, what emotions they might be having, and instead of taking the scolding personally, understand why they say all those things, So even a simple debrief and a chat over a cup of coffee, I think, with the juniors, with the nurses every week or so might make them understand the patients better. I don't know if I'm getting it correctly, but I just want your comments on that.
Yeah, I think you are 100% correct. And then what you just said made me think about the situation in my own previous universities, that we would not only trying to find time, we are trying to find space for people to do that. We couldn't find any. Is that in if you look at what the senior management level, at the senior management level, the people don't think that in the medical school we need a common room.
Oh, I think in our ICU in SGH, Joanna has a common room. Correct, Joanna? The one we have.
Yeah, but the problem is, you only have like 5 people allowed in the room. Otherwise, the auditors will come and they will hound you. So it's
that is going to change from 26th February, right?
Yeah.
Right.
The social distancing for COVID, no more. I think it's ended already. You can mask up and be in the same room. How many other people are there?
Right.
So you don't have a common room over there in Taiwan for sharing?
No. I mean in Hong Kong. No.
Oh, in Hong Kong. Sorry. Okay.
Yeah.
That's quite sad.
In Hong Kong, land is money.
Same here. But make it taller instead of wider, the buildings.
Yeah, thank you, Roshan. Yeah.
Any last thoughts you'd like to share, Harry, before we head off to lunch?
No, I just want to take the opportunity to thank you for this opportunity. I learned a lot from you, and then I'm trying to. If you are interested in my own program, so please get in touch with me. I really also I hope to come back to Singapore in person soon to do meaningful things together.
Great, thank you so much. How should we move on from here, Anh Kun?
Yes, thanks. We'll be happy to link up amongst the audience and the speakers, definitely. Just let me know. If not, then it's lunchtime now, so you'll come back at 1 p.m. Thank you, everyone. Thanks, Harry. Thank you.
Thank you, Inquan. Thank you.